Recording. All right. Well, I want to welcome everyone today to join our February webinar series on stroke and STEMI update. Today's speaking is Teresa Jenkins. Teresa is the unit manager, systems of care for stroke and STEMI at MDHHS, Bureau of Emergency Preparedness, EMS, and Systems of Care. Joining her is Eileen Warden, Systems of Care Manager from the same agency. And from there, I will have you all take over and share your screen.
Okay, thanks. Good. I guess it's afternoon now, everyone. It's nice to see some familiar faces of folks that I've worked with on the trauma side as well. So a lot of what I'm going to be sharing should not be foreign to you all. We're going to be giving you guys an update on the systems of care. In total, we're going to look at some things that will affect all of trauma, stroke, and STEMI, and then some specific things for the stroke and STEMI folks as well. So I wanted to start out showing the organizational chart as we've now worked really hard to get everybody integrated into our org chart, and so people can get a nice clear layout of how things work. Again, of course, here is our division here where Eileen and I work, and then we have three advisory committees, statewide advisory committees. We have a trauma, a stroke, and a STEMI advisory committee. Those folks are made up of folks that are appointed to the committee. They meet requirements like for trauma, there'd be a trauma surgeon, there'll be MCA representatives, there'll be a trauma program manager. The chair from our designation stack is on there. There's EMS representation. As well in stroke and STEMI, same thing, representation from the respective physicians and program managers for both stroke and STEMI, as well as EMS representation on that committee as well. Those committees we meet with bi-monthly or every other month, and we talk to them about things going on in trauma. They can help us make decisions about things that would affect our regional or our programs. They're a great source of information and subject matter experts for us, so we really do appreciate all of the membership on that group. Then we have our regional systems of care. So we have 8 regions in the 8 medical regions in the state, and then each region will have a regional trauma advisory committee, and right now a regional cardiovascular advisory committee. So early on, the stroke and STEMI folks will be working together to do some of the work that is done at the regional level until we build out the program and until we have the ability to add more things into the regional application and expectations and objectives for those groups. Each advisory council or each regional system trauma and cardiovascular will also have their own professional review standard organization committee. So those folks will be looking at that PI or quality assurance side of the house. And then they will have small subcommittees off of them depending on what needs to be done. In the trauma side of the world, we have injury prevention. We may have folks that convene for data. We could have folks that would convene for communications or anything specialty that might be needed, as well as that same thing will happen on the cardiovascular side as well. So I wanted to give a little update again for those folks who aren't familiar, sort of how the systems of care works. We utilize 6 pillars by which we are sort of the building blocks for our regional work. Each region will complete an application and a work plan that's done every 3 years, and it outlines the objectives that they will work on regionally under those pillars. So the next few slides, I'm going to show you the different pillars and sort of highlight in there where the stroke and STEMI objectives are built in for the upcoming regional application that will be submitted for 2027. So the big one, and one of the big ones, first ones, is injury prevention and risk reduction. So again, we work with agencies, organizations, again, on the trauma side, things like we'll work with our EMS partners, we work with our hospital partners, we'll work with our community or local health partners, as well as looking at some of those big organizational things. A big one, for example, is STEADY through CDC, a program that's a big through CDC for elderly falls. We use analytical tools. We look at we use the data registry. We look at common injury patterns within regions, and then we build regional injury prevention programs. And we'll be doing the same on the stroke and STEMI side, looking at data, looking at things that happen within the regions that would inform what types of risk reduction programs that we might want to focus on regionally. And then each regional service line then monitors, assesses, and evaluates those programs, how they're working, if they're being utilized, who's doing them, and how much they're being attended, and how those injury preventions are helping the community, how it's weighing out in the community. So in this upcoming application this year, one of the things that was added specifically for that will address stroke and STEMI will be that the regional systems of care integration for national programs and program evaluation, and looking at building risk reduction, identifying risk reduction programs that are successful, that are evidence-based, that utilize data, and those programs that could be utilized regionally to build those regional risk reduction plans. So we'll be working with hospital programs. What are they using? What are folks using nationally? What are we seeing works? What doesn't? And working on trying to sort of collate those programs and then put them together to build risk reduction programs that would accompany the trauma injury production or injury prevention programs in the region. So it will address the regional needs of the people that live within those regions. Um, on the trauma side right now, currently, and will ultimately then eventually move into stroke and STEMI, we look at communication. And so we really look at a coordinated communication system that links the hospitals, the life support agencies, the whole EMS system in the region as a whole. So we do look at, and we do this in conjunction with our healthcare coalitions, we look at what types of communication resources are available in the event that there is some type of communication issue that causes phones not to work, that could cause computers to go down, that could affect how we effectively report from one hospital to another in transferring patients. So we look at making sure that we have a system that's built up that will support us being able to communicate between EMS and hospitals, and then tertiary centers for those that are transferred, to make sure and to ensure that patient information is getting passed along throughout their movement in the healthcare system for trauma, stroke, and STEMI. As well, we look at the infrastructure that we have built within the region. So we look at the membership of our regional advisory network boards. We look at the membership of the advisory committees. We look at who's on our professional review standard organizations. We look at the governance and how is that working? Are we actually able to do the things that we're trying to do within those regions to strengthen the systems of care? We look at medical oversight related to EMS. We look at EMS protocols and how patients are being cared for pre-hospital, as well as we look at things like interfacility transfers and what's going on there. We also look at what is the current evidence-based medicine, or what is the current care patterns that we're seeing, and making sure that our larger hospitals are sharing things with our smaller hospitals. When they talk about program building, we look at what when I built my stroke program, I did this, or when I built my STEMI program, I did this, and this is what worked for us. So we look at that entire infrastructure to make sure that it supports the needs of the region, and again, the folks that are in that regional community, to make sure that the system is strong and is doing what it needs to do. One of the things that we have consistently started to look at is continuum of care. So again, we know that the care for the patient, the trauma, stroke, or STEMI patient, doesn't just start at EMS and stop at the hospital. We know that there is a rehabilitation phase for many of these folks. So we do look at those resources. What are available in the regions? What are some of the issues of getting those patients to those regions? How are there to those patients? How are we utilizing those resources, and how can we strengthen the use of those resources? So we do consider rehab all the way through discharge when we look at those patients for system of care. And then we look at education, certainly a huge component. We want to make sure that the workforce that's out there is competent and that they have the most up-to-date information on care for patients in trauma, stroke, and STEMI. So we look at pre-hospital education, we look at education that's going on in the hospitals, and we try to make sure that we can support some of those education endeavors for folks as they need it. So, we do try to get it regionally. We try to share resources. And like an example for us is physicians and advanced practice providers that care for the trauma patient need to have advanced trauma life support. So our regional coordinators make sure that they, are up to date on where those courses are being and trying to make sure that if someone's having difficulty finding that course, that we can help support that course. We try to be knowledgeable in the information that those courses are having so we can also, speak to them intelligently and make sure that folks know the importance of getting that extended education for the care of their patients. And then lastly, we look at performance improvement. So it's very important within the regions that we continue to look at the work that we're doing and is it working and how can we improve it. Another great example for like performance improvement is one of our regions really looked at why someone may bypass a hospital for a particular patient population. Orthopedics is an example. So if you have several hospitals that are capable, why would you bypass one for another? Why would you choose one hospital over another to take a particular patient? Is it due to the injury? What do they look at? We look at interfacility transfers, and is there a delay in patients being able to be transferred, and what is that causing it? Is there difficulty with the process in general, getting patients transferred out of the hospitals? Is it affecting the length of stay, the time that a patient may spend at a smaller facility on, waiting to get to that tertiary care? So the regions do look at a lot of that. All the different quality assurance and performance improvement measures within the region and do try to do work to improve regionally. They work with their regional healthcare partners to try to make improvements when they see that there's an issue there. One of the objectives under performance improvement, and one of the things that we're going to be looking at related to that would include stroke and STEMI as well, is we're really going to try to do an assessment overall of the needs of the general medical community. We're going to look at docs, nurses, EMS, and all the other like injury prevention, risk reduction data folks concerning trauma, stroke, and STEMI. We're going to collect information. We're going to look at assets available. And so it will sort of give us a really good picture of where we're at and, how we can move forward in building the system. So we have some projects and timelines, some priorities and things that we're going to be moving forward with now to work on furthering the system and getting our stroke and STEMI partners really ready to start doing the regional work. Next week, March 4th, we're going to have a large meeting with our stroke and STEMI advisory committees and some additional partners, and we're really going to start to hone down on the work that gets done regionally. We're going to look at the applications that are done and what regional work is done to complete those, to build the objectives, and to get those ready for use. We're going to set meeting dates for our advisory committee, and we're going to start getting meeting dates up and around so that we can get our regional cardiovascular advisory committees ready to get up and start running so that they can start working on their portion of the regional application as well as meeting partners and building their regional structure. We are starting to look at a process to designate stroke and STEMI facilities. We currently do that in the state of Michigan for we designate all of our ACS facilities. We also have the option for our level 3 and 4 hospitals to be verified by the state of Michigan and designated as well. We have that process built for them, so we are just looking at the process specific for stroke and STEMI as they will be coming to us already verified by an accrediting body. And then again, the regions are building their systems of care authority applications, and they're really looking at those how they're going to incorporate stroke and STEMI and get those folks up in meetings so that we really can get their group together and get them start doing the work that we need them to do to start building their regions. Uh, some things that we have sort of looking down the road. We are currently in the process of building our trauma registry migration. So we currently we're at ImageTrend. We're moving over to a different product. We're working on that migration. We're hoping to have that completed by 2026, September of 2026. For anybody who's done a data registry migration, that's a lot of work. So we've been doing that. It's been a lot of time spending there doing that. So as we've built that, the data collection for stroke and STEMI has been deferred because it's just really been a pretty big process building and migrating that data over. And so we're really, just hoping to take the registry building for trauma and utilize the things that we've learned there to then move on to the stroke and STEMI and hopefully make that a little bit of a smoother process for those two registries when we build those in. We initially thought, early on when we started this, we thought the registries would be up and running when we were ready to build and put get the regions meeting and start doing the designation process and all the things for stroke and STEMI. But we have worked with AHA. We are going to use the get with the guidelines for the dictionary, so we do have that set, and so we're working on building that stroke data dictionary now, and then we'll get that STEMI data dictionary built behind it. So again, when we're ready to build those registries, we'll have our data dictionaries all set and ready to go. Eileen, do you have anything else on the data piece? I'm not sure I hit it all.
No, that's it. We made an educated decision early on that we would want to have the registries up and running on the new one with a new software vendor, and then once and trauma kind of led the way because we've had trauma registry data for 14 years, and then we could move into more easily, as Teresa mentioned, move into stroke and STEMI. That has not been the case. We're still working on standing up that trauma registry. But it is intended to be a one registry for all three of these service lines. So the front facing page will have, the demographics in there, and then a tab behind it would be stroke, a tab behind that would be STEMI. That was the intention of the design. And we're still waiting for the vendor to put all those things together for us. We're working with them hand in hand to make sure that we do get exactly what we had envisioned. But translating, I'm sure you all, if any of you have been through an Epic upload for your building, you understand that transferring programming and a patient care record or a registry into programming is not a simple process. So we are working on it. However, we've pivoted, as Teresa very capably mentioned, into building the regional work and our charge is law-driven, administrative rule-driven, and to integrate these three service lines together, stroke and STEMI, into the existing trauma system. And one of the action items to do that is this regional new application, which will give voting power for the members who are on the Cardiovascular Council to inform the group about how things should work in terms of a stroke and STEMI system of care. So it's time to do that now. And we're going to move ahead with that. The application will be completed and voted on and approved by the department by the end of this year. And then they'll start actually doing all those objectives starting January 1 of 27.
And we are excited to get folks meeting. We'd like them to start meeting quarterly. Our trauma region folks meet quarterly now, and so we're hoping to just incorporate our cardiovascular regional meetings into that same format. We will ultimately here be putting out an application for folks to apply to be on the advisory committee. That's in the administrative rules. It's just a quick hey, give us some information and what is your role at your hospital, where you at, and then those go to the advisory or the System of Care Advisory Network Board, and those get chosen and the advisory councils get picked, and then they will get those folks meeting. And so we're super excited to get folks up and meeting and starting to do the regional work. And then again, like I said, sort of getting that designation process. We do have some folks that are really interested in becoming a designated facility at the state. So getting those processes built and ready to go.
Yep.
So, oh, go ahead.
No, I was gonna say just yep.
Yeah. So some opportunities for engagement for folks that are on this call. Certainly, we do have our Systems of Care conference coming up really quickly, March 10th and 11th in Muskegon. We will be doing some presentations there. We've got some folks talking about how they built programs. We've got folks talking about risk reduction programs and injury prevention. We've got just some really great clinical and operations programs, as well as all of the coordinators, the stroke and STEMI and trauma coordinators will be there, and our staff. So more than happy to engage and talk and answer questions there. Certainly in that programming and educational opportunities as you build your regional cardiovascular advisory committees. And I do know from doing the trauma work that some folks that sit on the trauma advisory committee will be the same folks that sit on that cardiovascular advisory committee. So they will be great partners in program building and educational opportunities. One of the things that we did early on in the regional trauma advisory committees was really just talked about how do we build a trauma program, right? We had our folks that had built programs. We had our level 1 and 2 facilities really there to help guide, to provide resources, to answer questions. We did a lot of educational opportunities. We talked about patient care. We talked about performance improvement processes. We talked about running and creating or building or entering data into a registry. We talked a lot about injury prevention programs and what worked and what didn't, and how do you integrate them into your communities. So I really feel like at those early days, we really had a great opportunity to help folks build programs and be successful. So I'm hoping to see that same enthusiasm happen with the Cardiovascular Advisory Committee, because we have so many folks that have great stroke and STEMI programs that they would be assets to the folks that are currently looking at building new programs. And then again, certainly just input on risk reduction and injury prevention initiatives. So, we love to hear what works and what doesn't. We love to hear about great programs that we can take out to our regions, to our hospital partners, to our EMS partners. A great example for us is Stop the Bleed. We heard about it, we got some folks trained, and then it went like wildfire. And I feel like we did tons and tons and tons of Stop the Bleed education out here. And I feel like, it really made a difference in communities. And so, we really want to make sure that we're doing that same kind of work throughout the stroke and STEMI communities as well. So really, things that you want to share with us here at the office, things that you want to share with your regional coordinators, we are more than happy to take that information back as we start to, again, build programs, look at meeting agendas, and look at the types of things that will help our programs early on the cardiovascular advisory committees to start to build their regional systems. This last slide is just the names, and not just, but it's the names and of our coordinators that we have here. Again, on our State of Michigan Systems of Care website, there is a link that will have all of their email information on it. We have 4 coordinators, 2 stroke and 2 STEMI. Each one of them is Mark and Christine are covering 1, 2 North, 2 South, and 3, and then Liz and Penny are 5, 6, 7, and 8. So they're 4 and 4, but certainly can answer any questions about the work related in their areas as well. Before I turn off the slides, Eileen, do you have anything else to add?
No, I'll just reinforce that we do have section staff who are working in the field. Everybody on our team has a clinical background, so have either been there and done that or are very familiar with the work. So, and they have been a great asset to helping all of the people out in the field and the regions start to think about how they're going to work together, either we're now calling it the Systems of Care Authority areas, and that's the name of that new application, because we're now but charged again by law to integrate these 2 service lines, stroke and STEMI, into the existing system that we have. So they have been they have been and will continue to be, I think, a great asset and a go-to person for questions.
And they will probably start to be reaching out to hospitals to start to get contact information for the stroke and STEMI programs, much like we have for the trauma programs, so that we can make sure that as we send out informational emails, as systems updates and things like that, that folks are included in that information, so that you're getting the most information. And then again, so that they can update when regions start meeting.
We know that changes a lot.
Yeah, so now would be a fantastic time to raise your hand, ask any questions, put them in the chat for Eileen or Teresa.
See, it's a quiet group because many of these people have heard me talk before and they're like, don't get Jenkins started because she'll just keep going.
We can talk about the weather. In Michigan, that's always good.
Okay, well, if there aren't any questions, we will not hold you captive for a half an hour because I'm sure people want to eat lunch and get back to their daily busy lives. But we appreciate you all for joining today. I will be sending out a short survey after the call here today. If you could fill that out, we would greatly appreciate that. Again, Teresa, Aline, thank you for speaking today, and slides and video will be up on the website within the next week.